Hello. My talk today is on diagnosis and treatment of aortic aneurysm. It is a little bit different than the previous two ones. You will see that I'm an interventional radiologist, and believe me, it's really hard to choose something which is basic and to divide something from basic to advanced. It's really not easy. I try to have some learning objectives. It's imaging techniques, of course. That's what we need to know about the aneurysm before treatment, and something about nowadays treatment, of course. Sir William Osler, a long time ago, in 1902, wrote a very distinctive question. It was not a question, of course, it was just a sentence, that there is no disease more conducive to clinical humility than aneurysm of the aorta. Why is that so? It's all because the aneurysms ruptures, and the mortality rate is really high. It's going up to 75%. The rupture of the aneurysm affected in history some very known persons. We have in 21st century more aortic aneurysms. Why is that so? It's because of aging of the population. It's because of all these cardiac things. Cardiologists save our lives, and then we have more aneurysm. And the second point is that we have better diagnosis. Radiology is year by year better. So some basic epidemiology. The incidence of thoracic aneurysms is about 5 to 10 per 100,000, but incidence of abdominal aneurysms is much, much higher, is up to 45 per 100,000. When we have, if we look to sexes, male sex is 5 times more frequent. And if we go for percentage of localization of aneurysms, we will see that abdominal aortic aneurysm is a king, and when it's together with iliac aneurysms, it's almost 80%. About 20% is thoracic aneurysm, and thoracoabdominal and isolated iliacs are less percent. What matters in the diagnosis of the aneurysm? It is, of course, the size, the diameter. I put 50 millimeters. 50 millimeters is a general borderline for abdominal aortic aneurysm. If we talk about thoracic aneurysm, someone might say it's 55, even to 60, but when it's a woman, we will again go to 50. What's important? If we have the aneurysm below the borderline measurement, we must observe the patient. And if we have the aneurysm is more than this borderline measurement, we have to propose the treatment to the patient. We have a lot of imaging techniques to diagnose aneurysms. Any algorithm. Today's, of course, if we go to plain X-ray, when I started, it was relatively frequent to have the incidental finding during this plain X-ray. Nowadays, chest X-ray is still done, but I don't think it's very popular to do abdominal X-ray in admission departments. It's not an issue. Of course, ultrasound, angiography, and CT and MR. Let's get closer to those. I put some advantages and minuses and drawbacks of these techniques. If we have ultrasound, it's of course totally non-invasive. It's repeatable, it's inexpensive, it's fantastic. It's widely available, so it's very good for initial diagnosis. Doesn't matter that we have this imaging live or not. I don't think so. It's not a special thing, but it is also very good. If I said before that we have aneurysms smaller than borderline, we can follow the patient with ultrasound, and it is done. It is of course in case of abdominal aneurysm, not a thoracic one. unfortunately, we don't have enough details, especially in the measurements of length, to plan the treatment. So we have to perform a CT. A CT gives us very good details, calcifications, thrombus. It is available. It is economic, I can say. The measurements are very precise, and it is finally very good for treatment planning. What about what about radiation? It is, of course, nowadays trend is to lower radiation. We know that, but it still is. Someone says it is also high dose of contrast, iodine contrast medium. But all these images and reconstructions, we can have MIPs, volume reconstructions. It is probably the best possible diagnostic technique to have to diagnose and prepare treatment of aortic aneurysms. What about MR and MR-angio? I think that one day everything will be done only by MR, and some other techniques will be withdrawn from the market. But nowadays, it's still not better. It is, of course, non-invasive, no radiation, no contrast material, no iodine. We have good reconstructions, but we still have less details. And availability is also less than CT. It's more expensive and less convenient for the patient because it lasts relatively long. But I think we can, in some cases, do in some centers, it is done to have this sort of imaging before treatment. What about angiography? It is of course only luminography. It is invasive. It's costly, but I wouldn't totally rule out calibrated angiography from diagnosis, especially when we prepare the patient for stent grafting. We must remember that angiography is the only anatomic imaging technique. We have direct measurement from calibrated catheter. And believe me, we need accurate length measurements. So if we have nice aneurysms, it's okay. But when aneurysm generally causes tortuosity of the arteries, and we have like this, we can predict better how the stent graft and the graft will fit to the aneurysm. We would always like to have this like in this case. But we must remember also that most of aortic aneurysms are diagnosed occasionally. And the patients are usually symptomatic by now. And the ratio between incidental and suspected finding is like 9:1. So routinely done abdominal ultrasound may reveal the aneurysm. Routine chest X-ray will reveal something wrong in the chest, and we will see the aneurysm. Even if we do some routine CT because of any other problem, which is very popular, we might reveal the aneurysm. And finally, if we do very frequently by now MR of the spine, lumbar spine or cervical spine, we might see something which is the aneurysm. What then? In those cases, in all of these cases, the patient will be sent to CT to have the overview of the whole disease. I think it is a little bit different to diagnose patient who's going for open surgery and for endovascular treatment. What we need to know about the aneurysm before surgery. Usually we have ultrasound. After that, it is CT. And believe me, vascular surgeons don't like most axial scans. They are fond of reconstructions. They don't like MIPs. They mainly use 3D volume reconstructions. And what is all about? What is all this diagnosis about? It is about to put the tube graft or bifurcated graft. So if we go for EVAR techniques, we definitely need more details, because successful stent grafting is all about good sealing. Good sealing, good proximal sealing, and good distal sealing. If we talk about abdominal aneurysm, the queen of the success is the neck of the aneurysm. It's below renal part. It might be conical. It might be irregular, angulated. It might have some calcifications or thrombi. This is very important. When we talk about thoracic aneurysms, we always look at left subclavian artery and the distal landing zone. So, let's see the aneurysm. This one, I could say, it is actually perfect for any treatment, because the neck is long and straight. Also, iliacs are straight without any aneurysmatic changes. So, if we want to put the stent graft to this patient, we can choose any device and we will succeed, because it's very nice. We put the stent graft here, and what we look for? We look for good long-term result, and this long-term result is good then when the aneurysm, more than 60 before treatment, is getting to shrink. It's about, if it's going to shrink about 50% through the year, it is the perfect result. It's not an issue in all cases, but in 1/3 it is. We can see here a little bit more difficult, AAA for stent grafting. The neck is still nice. It's still long enough. 2 centimeters is 2 centimeters of sealing is fairly enough. Iliacs are tortuous. Believe me, you will see this in most of patients, that the aneurysm is going straightly further. So it must cause tortuosity of iliacs, and in many cases tortuosity of the neck. Here we have angiography and stent graft, and these cases are very nice to be done. But sometimes we might have very difficult patient, very difficult AAA for stent grafting. And if patient is not fitted to open surgery, and believe me that most of patients nowadays, they have doctor internet and they don't want to be operated. They want to be stent grafted. Believe me that. And please have a look on this extremely angulated short neck, and also bad iliacs. In cases like this, I would like to, before stent grafting, have calibrated angiography to have possibility to measure the stent graft very well, to be fitted perfectly. That's also our radiological advantage over vascular surgeons, that we have possibility, and we should do this in a very elegant way, exactly from renals down to hypogastrics. In these cases, durability of stent grafting is much, much better. What about thoracic aneurysm? This one looks perfect. Looks perfect because we have this proximal neck, very nice. The aorta is healthy in this part, and also the distal landing zone is very good. So we call this procedure 10-minute procedure, because advancing the aneurysm to release it and balloon it lasts really 10 minutes. It is very, very easy. But of course, not in all cases. In some cases, we have very short proximal neck. And that's the question what to do in this case. It is to be done. It is to be closed. We may close left subclavian artery. We may cause left subclavian steal syndrome, and most of patients will live without any consequences. And some younger patients, especially working physically, vascular surgeon is doing bypass, just like in this case. Please have a look. But we have something new to propose to the patient. We can use the special grafts with a scallop for left subclavian or fenestrated graft. It is all to have better sealing. If we don't have anatomical good sealing, we will have better sealing with such grafts. There is a branch graft which is coming. It will be obtainable in Europe this year, and I think it is also a very good thing. Sometimes we cannot put the stent graft exactly below left common carotid artery. Then we also could put this graft to left common carotid artery. It is a new thing. Let's talk about aneurysm ruptures. It is, of course, the best way is to recognize possible rupture before it's coming, to its prevention and to save life, of course. Do we have typical features? Can we talk about typical features of possible or ongoing rupture in ultrasound? Yes, irregular shape of the ultrasound, and sometimes they call it blister, is a feature of possible ongoing rupture. In some aortic cases, it's not an aneurysm, but they call it penetrating aortic ulcer. It is also the feature which make us more careful in diagnosing patients. Generally, irregularity of the shape and echogenicity, which is non-uniform. Echogenicity of the thrombus may tend to possible rupture. And if you can see this, it was possibly ruptured or partially ruptured aneurysm, and those two are already ruptured. What about CT? CT is in CT is much easier to have that sort of features, imaging features. It is a partial rupture with calcifications around, like this or like this one. Also, the irregular shape of the lumen. What means it's irregular? Irregular when we talk about the thrombus, of course. All these pictures are showing possible and ongoing rupture. So let's see ruptured aneurysm. Aortic aneurysm does not rupture like a balloon, just like that. And sometimes, in most cases, we have time. It's not days, it's hours. But if we are able to treat the patient in 2 or 3 hours, in most of cases, we will succeed. Here we have a ruptured aneurysm. It's CT, it's angio, and after stent grafting. And one more case like this. It is most of these patients have abdominal pain, shock symptoms, or sudden collapse. And again, the patient with ruptured aneurysm on CT, the CT is usually done during admission, and then the patient should go to interventional room to have stent graft. If we perform angiography in a patient with shock symptoms, we hardly see renal arteries. We hardly see some other arteries, some SMA, for example, because those arteries are spasmodic, because the spasm is because the patient need the brain to be fed. And please have a look. This is a very distinctive image. And when we don't see very nicely abdominal branches of the aorta, and after stent grafting, it is half an hour later, we can see all these branches very nicely. This means that we did a good job at the time. One more case of ruptured aneurysm. It is a plain X-ray in CT of ruptured descending aortic aneurysm, and again, stent grafting also a very easy procedure because the tube graft is, to put the tube graft is just 10 to 15 minutes. What about some more complicated aneurysms? Now I will focus on some contemporary techniques which are a bit more difficult than ordinary stent grafting. If we have AAA with bilateral iliac aneurysms, when the patient is relatively young and he works, and sometimes also the patients ask us about erectile functions. So we may propose this patient a special graft which has an iliac branch. It looks like this. It is a special part of a graft with the branch, and if we connect hypogastric artery to the stent graft, we might keep good feeding of the pelvic structures. And what about juxtarenal aneurysms? It is for many years it was not possible to do anything, but we started 2011. The patient has aneurysm in here and also both iliac aneurysms. So we could perform also iliac branched aneurysm, but the clue was fenestrated graft with fenestrations for both renals and in this case for superior mesenteric artery. And finally, what to do with thoracoabdominal aneurysms? As I mentioned, it's not a huge group of patients, but during last years we observe that we have more and more patients like this. It's because of aging possibly and better diagnosis, and we must deal with it. So I have here a CT of after the hybrid operation. Believe me, so we can see the stent graft covering the whole aorta, and the bypass from common iliac bypass, and from this bypass we can say bypass feeders to both renals and celiac trunk and superior mesenteric aorta. It is a very nice picture, but it's not so easy. The patient might not survive this sort of operation. It is one of the biggest operations the patient might have. So it's not a very good idea, such a debranching technique. So that's why companies and technology went over it, and now we can perform thoracoabdominal branch stent grafting. It's obtainable for the last years, and we can see CT of such patient, and the stent graft going from left subclavian artery to hypogastric arteries with branching of abdominal vessels. I would like to thank you for your attention, and of course make it remember that aortic aneurysms are it is a family disease in many cases, and we'll have patients who will come and say, okay, we had or I had aneurysm, aortic aneurysm in my family. My grandpa had possibly something like that. I would like to check. So we will do ultrasound first. We will do CT, and we will see, and we will have more and more patients like this. Thank you.